Pharmacology of the GI system. So just some basic stuff. So if somebody is undernourished, it can be either related to intake, absorption, or utilization. Food supplements include Ensure. Basically, it comes down to a differential diagnosis process, figuring out why they're undernourished before you use any sort of a supplement. What can you do? You can use dietary. There's enteral and parenteral. Those are going to be reserved usually for inpatients, enteral and parenteral. Obesity, of course, is a very common but very concerning and problematic thing to treat. Anybody that's 20% over their ideal body weight or a BMI greater than 30 is considered obese. This is a blunt instrument when it comes to the BMI, because if someone is very muscular, they may have a high BMI. So the next thing to look at usually with the BMI is the waist circumference. So if you have someone with a high BMI but a good waist circumference, I don't think that clinically you would treat them as if they have obesity. Diabetes, hypertension, back pain, all sorts of things are associated with obesity. The challenge is whether this is an independent risk factor or whether these are related to the underactivity and other things that cause the obesity. It is interesting to me because if you take someone who is very active but just seems to be heavy because of genetic factors, their risk factors are slightly increased, but rather minimally as compared to someone who is obese because they are eating very poorly and not exercising. So what do? You lower their calories and you increase their activity. Boy, that's easy, huh? In fact, with most people, the only thing that I find is helpful is to lower the carbs in their diet. This lowers their appetite and just by default will lower the amount of calories. It's much easier than suffering and depriving oneself. It really does require a change in the way of thinking, though. So to treat obesity, you can either use behavioral approaches, dietary approaches. Medications are somewhat helpful. The problem, of course, is that many people will lose weight with medications and then gain it back. Options include stimulants. There's some other appetite suppressants besides stimulants. Surgery, such as the bypass, the stapling, the banding, the sleeve. All of these are used in extreme cases, and when people have been unsuccessful, it is something that is reserved for people that you don't have success other methods. So specific medications, phentermine is a stimulant medicine. It's actually part of fen-phen that got a lot of bad press years ago. The other fen was fenfluramine, which is actually an FEN. The fenfluramine was associated with certain types of cardiac disorders, and so it was taken off the market. Plain phentermine is far less effective than phentermine and fenfluramine, but with some people you can actually jumpstart them, give them a little bit of weight loss. Again, the problem is that many people don't believe in using these medications because the ability to sustain that weight loss is pretty limited. Fusimir is a medicine which adds the phentermine, adds some topiramate, which is an anti-seizure medicine that we just happen to notice that people lost weight. Ally is a fat blocker. The problem with Ally is that by blocking the fat, it actually causes the fat to continue to travel through the colon. This tends to grease up the bowels and cause pretty substantial diarrhea in most patients. Belviq, or lorcaserin, is a serotonin agonist, which seems to regulate appetite and mood. Is fairly expensive at this point. Seems to have some benefits, but the benefits are relatively mild. Contrave is a combination of bupropion and naltrexone. Naltrexone is felt to decrease addictive type behaviors, not only in people with opioid issues, but also in alcoholics and also in people with food addictions. Saxenda is actually the same medicine as Victoza. It's just given at higher doses. whether it causes its weight loss related to the nausea or whether there is a direct effect of that GLP-1 agonist is controversial. In fact, though, some people do lose substantial amounts of weight on it. Other meds which cause weight loss, especially those used for diabetes, the GLP-1 agonists, as noted, Victoza, but Byetta and Trulicity also do have it. Metformin causes you to lose about 4 pounds, which is not substantial, but is way better than some of the other diabetes medicines like glipizide, which usually result in a weight gain. Insulin, of course, almost always results in a weight gain as well. The SGLT2s also do have a modest decrease in weight. They lower the blood pressure some and are pretty effective diabetes medicines. Again, the big problem with them, of course, is cost. So a specific issue, GERD. GERD is gastroesophageal reflux disease. Very common. Patients will have a lot of heartburn type symptoms. When the sensation comes up in the back of the throat, that's technically called water brash. But a lot of people have fullness and a sensation of acid in their esophagus. A lot of these people will wake up in the middle of the night coughing. Of course, if someone has a persistent cough, GERD will be on your differential. GERD can cause strictures, it can cause scarring, can cause chest pain, of course, and unfortunately when somebody presents with chest pain, if they have GERD, it makes it that much more difficult to figure out what's really going on. And they can also have pharyngeal type symptoms and laryngeal type symptoms such as hoarseness if the vocal cords are continually bathed in acid. So how do you treat GERD and also peptic acid or peptic ulcer disease? We'll talk about that in a minute. H2 blockers lower acid, but they really only work on the histamine receptors. PPIs block the hydrogen potassium adenosine triphosphate enzyme system, which really blocks the acid in about 3 different ways. They can reduce the acid by as much as 99%. H2 blockers decrease it by a much more modest amount. So that's why some people start with an H2 blocker and go to a PPI if it doesn't work. Alternatively, a lot of people will use a PPI, get the symptoms under control, and then try an H blocker to see if that's adequate. H2 blockers, of course, are substantially cheaper and maybe have less side effects. So what side effects are we really worried about with PPIs? They might increase the risk of osteoporosis. Calcium absorption is dependent on having a low pH in the stomach. So if the pH rises because the acid decreases, then the calcium might not absorb, and there's a theoretical increased risk of osteoporosis. I'm not aware of any studies that have actually documented fractures, but it is a very real theoretical risk. We say that you can't use Plavix with PPIs. The cardiologists have really kind of backed off with that. Some still do restrict the use of Plavix and PPIs together. Others say PPIs are just fine. You definitely want to be aware of the particular cardiology's thoughts. But in general, you can use PPIs and Plavix together. Does the use of PPIs increase the risk of C. diff? There is some evidence that it really does. For a while, we were putting everybody that went in the hospital on a PPI. We've now sort of backed off on that a little bit because of that increased risk of C. diff. PPIs are cytochrome P450 drugs, 2C19s. So they also metabolize the same enzyme as warfarin, and then the cytochrome 3A4s, which are statins and lots of other medicines. So antacids, lots of different options out there. There's calcium-based, there's aluminum-based, there's magnesium-based. And then there's some that use a mixture of the two. So alginic acid is what Gaviscon is made of. It's basically made out of seaweed, and it floats on the top of the stomach, we think, and therefore maybe decreases reflux. Hasn't really been proven, but it's a theory. There's also a theory that the calcium-based antacids, such as Rolaids or Tums, cause a rebound in the acidity. Again, many patients will use Rolaids or Tums. If they're using them every 45 minutes all day long, then you may want to try switching to some other approach, definitely a PPI, but also maybe trying a different antacid for those breakthrough times. Aluminum-based antacids, there's some question whether that's related to bone demineralization, and the antacids in general interfere with tetracycline, iron absorption, INH, which is used for tuberculosis, the sulfonylureas, and quinolones. So definitely, if someone's taking antacids, it should be separated from most of their other meds. So I really refer to this as usually more peptic acid disease than peptic ulcer disease. I think that with the advent of the PPIs, and especially the PPIs being over the counter, the number of people that actually end up with ulcers is a pretty small number. It does happen, but it's not a very big number. Peptic is a generic term meaning esophagus, stomach, or duodenum. And then, of course, ulcer means that it's worn all the way through that main layer down into the muscular layer. The most common cause of actual peptic ulcers is H. pylori. Usually we test for that with stool or with a breath test. Blood test probably really doesn't have a role in practice at this point. The gastroenterologist will actually take a sample and do what they call a CLO test, which stands for Campylobacter-like organism test. Just because H. pylori is similar to Campylobacter, and if the test is positive, they will treat the patient for H. pylori. There are a small percentage of patients who get ulcers related to severe stress, such as burns, but obviously in primary care, we wouldn't be seeing those folks. So how do you treat H. pylori? It's at least 3 drugs, sometimes 4, usually a PPI. Some use an H2 blocker if there's a contraindication to a PPI. One regime is clarithromycin and Flagyl. There's a bunch of regimes. You can familiarize yourself with this if you do need to do this treatment. Some of the recommendations include bismuth, which is basically Pepto-Bismol. It's actually a heavy metal and probably has more risks than what we realize, but is frequently used in that over-the-counter medicine. Usually treating 10 to 14 days. Some are trying shorter, but obviously you want to treat it long enough that it's eradicated. So what are the symptoms of peptic acid or peptic ulcer disease? They have pain, they have burning. Most of these people do not have bleeding, but about 10 to 20% do. The bleeding is usually melena. Melena is dark stools after a portion of the stool has been digested the blood. Hematochezia is bright red blood per rectum. This is usually associated with hemorrhoids, colon cancer, or diverticulitis. So obviously the workup for melena and hematochezia are quite different. So back to ulcers again, specifically to talk about how they're related to NSAIDs. NSAIDs will not infrequently cause ulcers, but usually these people do have symptoms. They've had some GI issues. There are a percentage of them that have no symptoms until they have a substantial GI bleed. And that, of course, is one of the risks of the NSAIDs. Obviously, if you have someone that perforates, you're going to have a tachycardia, you're going to have a low blood pressure. Usually they're going to have pretty substantial systemic symptoms. Duodenal ulcers are very similar to gastric ulcers. Usually the symptoms, instead of occurring with eating, they usually occur 1 to 3 hours after eating when the stomach and duodenum have emptied. Treatment is H2 blockers, PPIs, Carafate, Wilcote, bismuth, and the usual antibiotics that you would use for H. pylori. About 80% of the cases of stomach ulcers are H. pylori. About 90% of the cases of duodenal ulcers are. So diarrhea. Diarrhea is obviously a very common phenomenon. The vast majority of diarrhea is acute diarrhea, less than 3 weeks, self-limiting, not anything that really needs substantial intervention. But anybody that has increased frequency, volume, increased fluid content of stools, usually, as noted, that acute diarrhea, different definitions. This one's 2 weeks, but even up to 3 is probably reasonable. So what can cause it? Viruses such as the norovirus, very common. There are some bacterial causes. Interestingly, the majority of bacterial causes do better without antibiotics and without treatment and just running their course. Exceptions to this, of course, are C. diff, which usually does require a antibiotic approach. Right now, the change has just been made to make vancomycin the drug of choice. I personally think it's very expensive, and I have mixed emotions about that. Some folks are still using Flagyl, which used to be the drug of choice. The other type of diarrhea, which often does require a medication approach, is Giardia. Giardia will usually require treatment with Flagyl. But if you rule those two things out, you can usually allow the diarrhea to last a little while. The Sanford Guide says if someone's having 6 or more stools a day, or if their temperature is over 101 and they don't have bloody diarrhea, then you can just empirically treat them with Cipro, which covers most of the types of diarrhea. There is one common one, which I think is Campylobacter, which requires azithromycin, so that is another option. But stool cultures can be helpful. My experience has been that they're pretty rarely helpful, and I never do them if somebody has less than 2 weeks of diarrhea. Over in parasites, I found to be pretty unusually unhelpful. The primary parasite that we used to find would be Giardia. We now have an antigen test which tells us that way better. I've probably done 100 ONPs in my life, all of which have been negative. So I don't do it unless someone has a prolonged diarrhea, and especially if they don't respond to the initial treatments. Parasites, by definition, are just one-celled animal-type organisms. So rather than being, the usual, worms and things that one would think of. You can have diarrhea from malabsorption. If someone is lactose intolerant, they often will end up with a diarrhea when they eat lactose. Medications, of course, can cause diarrhea. One of the most common ones that I see is people that take magnesium supplements, and we'll have an ongoing discussion about the most effective magnesium supplement. Systemic diseases, obviously ulcerative colitis and Crohn's, allergies, and psychological. There's a lot of people who get diarrhea when they get nervous. So what do you do for diarrhea? Well, basically you treat the underlying disorder. So if there's a virus, you basically allow it to run its course. You try to keep the patient hydrated in the meantime, make sure they get enough fluid, little bit of electrolytes. I tend not to use Gatorade just because it has a lot of sugar in it, and that sugar actually acts as an osmotic laxative in many people. I tell them to limit their food, just eat a very light diet, no milk, no caffeine, and don't obviously overdo on the sugar. In the old days, people would recommend the brat diet, bananas, rice, applesauce, and toast. The American Academy of Pediatrics backed off from that about 20 years ago. It is something that will not die, of course, just because there's many people that have learned it and they keep teaching other people, and those people start using it. So many people use it now that have only been practicing for a few years. But I think the brat diet is way too restrictive, and that's the reason that the American Academy of Pediatrics stopped recommending it. Saltines are fine. It's not that the brat stuff is generally bad, although I think applesauce tends to cause diarrhea more and more people than prevent it. But just eating a light diet, a little bit of scrambled eggs, those kinds of things. Anti-motility agents, as long as you're sure that they don't have C. diff, just because they can end up with C. diff bacteremia if you slow down the C. diff too much. Imodium is the most common one that's used and probably the most effective. Imodium has only one M right after the I. There's a total of two M's, but one at the beginning, one at the end. Many people misspell this word, yet another one of my quirks. Kaopectate basically causes absorption of fluid into the intestine and dries the gut. So it does basically cause decreased diarrhea, not as effectively as the Imodium, so it's pretty much fallen out of favor. Pepto-Bismol is supposed to decrease the secretion of fluid into the gut. Does seem to work on some people, but again, most people use the Imodium. Lamotil is actually a narcotic-based medication which slows down the gut. It's no better than Imodium, and we had already talked about use of antibiotics if someone's having diarrhea 6 or more times a day. Constipation. Well, constipation is the other side of the coin. So it's people that are having infrequent or very difficult passage of stools. As people age, their colon slows down. They're on medications which cause constipation. Their diet does not have enough roughage in it. All of these may develop constipation. In severe cases, they can even develop fecal impaction, and that can actually be deadly. So find the cause if you can, and then fix it. So if the diet is the problem, they should increase their fluids and roughage. If they're just having slowdown related to age or medicines, sometime you want to add a laxative. If you can't change the medicine, obviously, if you can change the other medicine, it's better too. But the osmotic and irritant laxatives can result in dependence on the laxative. Miralax is much less likely to do that than the others, but the bulk-forming laxatives, such as the Metamucil, is the preference of a lot of people. And obviously, if it's really bad and you're worried about a fecal impaction, they may have to be disimpacted or have an enema. So there's some other GI drugs as well, pro-motility drugs such as Reglan. The big problem with Reglan is it causes tardive dyskinesia, which are dysfunctional movements of the face, some muscle stiffness. So we will use it short term. It does increase the lower esophageal sphincter and promote gastric emptying. So in people with diabetic gastroparesis, it can actually be pretty helpful, but again, should be used short term. So other things that can cause issues, we've talked about how the NSAIDs can cause ulcers. The phenothiazines and the furantoins can cause jaundice. Tylenol, statins, niacin, and phenazopyridine, which is pyridium, can cause liver damage. So this is why we only use the phenazopyridine for a couple of days at a time. It can also cause blood dyscrasias. But we do need to keep an eye on the liver tests for the statins. But niacin, of course, also needs to have those monitored and really does not seem to have any substantial impact on overall deaths. Pancreatitis, alcoholism is the first thing that most people think of. About half the people with pancreatitis do have alcohol issues, but the other half don't. But other drugs such as estrogens, flagyl, opiates, sulfa drugs, and thiazides can also contribute to pancreatitis. Probiotics, if you've got somebody with H. pylori, some people use them, but they're not going to be helpful alone. They might help prevent it, but there's not really compelling data to that effect. Antibiotic-associated diarrhea, there's some evidence that probiotics such as Lactobacillus GG tend to help treat that. The problem with these probiotics is they're about $25 to $30 a month. Many people would prefer not to use them, and the incidence of antibiotic-associated diarrhea is probably not high enough to validate doing it with every person that you put on antibiotics. So the use of yogurt, the use of some other things really doesn't have any strong data supporting it. So I tend to tell the patient that if they get diarrhea or start to, they can go out and get some probiotics, but I don't recommend it for just everybody that I put on antibiotics. Ulcerative colitis and Crohn's, these are inflammatory bowel diseases, not to be confused with irritable bowel disease. Irritable bowel disease is actually just basically alternating episodes of constipation and diarrhea. Many of these people have a predominant symptom, either constipation or diarrhea. The FODMAP diet, FODMAP, which is fermentable oligodimmonosaccharides and polyenes, tends to help a lot of people with IBS, irritable bowel syndrome. But a lot of these people, there's medicines that you can use. They tend to be really expensive. Generally, you have to rule out the really bad stuff, and then it is a behavioral approach. That being said, let's get back to inflammatory bowel diseases, which are totally different. Inflammatory bowel diseases include Crohn's and ulcerative colitis. These people have substantial inflammation of their small or large intestine. Ulcerative colitis, it's pretty much restricted to the large intestine, and Crohn's, it's more likely to involve the small intestine and other areas. Crohn's will have skip lesions that show up on scopes. Ulcerative colitis will usually have hematochezia and a substantial amount of bleeding. So what can you do for inflammatory bowel disease? Corticosteroids are what are used for flare-ups. There's a lot of people that go on a quinolone and Flagyl on a fairly regular basis. Most people, to try to prevent these kinds of things, go on a MAB medication, a monoclonal antibody. And these monoclonal antibodies, many of them attack tumor necrosis factor, which is an inflammatory thing which happens in many autoimmune process. And so there's 4 that I've seen used for Crohn's: Remicade, Tysabri, Entyvio, and Stelara. Most of these are also used for some of the other autoimmune processes for which we're using monoclonal antibody. They also decrease leukocyte adhesion and migration, so they do have a general benefit for not only Crohn's, but a lot of these autoimmune processes. So the aminosalicylates, if you've got a milder case, sometimes the sulfasalazine is given orally, sometimes the mesalamine is given with enemas, but using these medications can really decrease the symptoms. Corticosteroids are used for flares. Unfortunately, they do increase the risk of osteoporosis if they're used with any sort of frequency, and as noted, antimicrobials, including Flagyl and quinolones, are often used. Nausea and vomiting meds, sometimes these are used in Crohn's, but just to talk about them generally as well. If you've got somebody with nausea and vomiting, the first thing to think about is why do they have nausea and vomiting? Because if they have a bowel obstruction, you don't really want to take their nausea away because they'll be more likely to perforate their bowel. So you have to figure out why they have the nausea vomiting. If you have somebody that has norovirus, something that you really know what's going on, then giving a nausea vomiting med makes perfect sense. The most common one used nowadays is Zofran, which is also known as ondansetron. This is a serotonin agonist medicine for 3 are receptors of serotonin. Other things that can be used, there's a number of things in the antihistamine family. I use hydroxyzine quite often. It seems to give a little bit of sedation, but for most people with nausea, this is generally a good thing because they want to go home and go to bed. Tigan comes in a suppository. Benadryl can be used in children, again, if we're confident that their issue is not anything serious. The benzos are used mostly for chemotherapy type patients, but they can be used at other times. Ativan is a pretty good antiemetic. Haldol and anapsine are related to phenothiazines, but they are not technically so. And the cannabinoids do definitely seem to decrease nausea, although there is a weird rebound nausea that happens in some people that have heavy use of marijuana. The phenothiazines are a very common thing that we use. They block the dopamine. So compazine or Phenergan are very common antiemetics that we use. So other liver issues, couple of infections, hepatitis B and hepatitis C, both of which are much easier to treat now than they used to be, and we can manage them with medicines. And then hemochromatosis, which is an unusual condition, but one that if you're aware of, you can actually diagnose some people that are having chronic joint pain and concentration issues and tiredness, and really have a life-changing impact on their treatment. So hepatitis B, lots of different medications. Most people that I've seen are on Baraclude. This is a condition which is treated by GI. If you have somebody that has a positive test for hepatitis B, and this would be a positive surface antigen, that patient needs to be referred to GI. Most infection control physicians won't treat this condition, although some will. But you refer this person to GI, they evaluate their liver. Sometimes folks will convert to be surface antigen negative after an acute infection, and they probably do not need treatment. The only problem is if they become a chronic hepatitis B patient and have a chronic positive surface antigen, then they will require ongoing treatment because the inflammation associated with this infection increases the risk of liver cancer and also liver failure related to cirrhosis type processes. Hepatitis C, there's a couple of different treatments. Most everybody gets Harvoni at this point. It's the one that has shown the greatest cure rate. It's in the high 90s. These people truly are cured too. There are people that have hepatitis C who you do the hepatitis C antibody, it's positive, you do the viral load, and it's undetectable. These people have already fought off hepatitis C all by themselves, and it's at least 20 or 30%, maybe higher. I haven't looked up the data lately. So not everybody with hepatitis C needs treatment, but if anybody still does have any sort of viral load, they will need Harvoni or something similar. After they've had their treatment with Harvoni, they usually will go down to a viral load of undetectable. They never report a viral load of 0 just because you can't be sure that there isn't any virus in the system, but they will say that they can't detect it. Most of the people that are undetectable are really considered to be cured. So hemochromatosis, what's hemochromatosis? Well, hemochromatosis is an iron-loading disease. And people that get hemochromatosis will have joint pains, they'll have fatigue, they'll have concentration issues, and they also will just generally feel weak. They may have slightly elevated liver function tests. They may even develop diabetes. They can have decreased libido. The most common time of diagnosis is men in their 50s to 60s and women in their 60s. Although some of these people have been suffering with this for years. If no one's thought to specifically test for iron, the most sensitive test, of course, is the ferritin. Many of these people will have had symptoms for years. So you do a ferritin, if you do a transferrin saturation, if you do a iron profile, that'll also usually give you a high saturation and tip you off that you should be looking for hemochromatosis. There is a genetic test to see if someone has hemochromatosis, and usually hematology will do that. But you do need to be aware, because especially women, if they're still menstruating, they basically are treating their hemochromatosis by losing blood and losing iron every month. On the other hand, as they reach menopause, they will build up high iron levels and the negative effects of having a high iron level. The treatment is phlebotomy, sometimes weekly, sometimes monthly. And basically, they just try to keep that ferritin down at the very lowest end of normal and almost deficient. Most people will be able to maintain their hemoglobin okay with just a minimum amount of ferritin, but the hematologist will generally try to do phlebotomy enough. I've got at least a half a dozen patients with this. Most of them, if they keep up with their phlebotomies, feel way better than if they don't. So one more thing to be thinking about.